All right, so good morning, everyone. Thanks for attending today. So my name is Matt Medford, and today I'm going to be walking through essentially the first aim of my dissertation project, and I'll provide some of the analyses that were performed and some next steps. But the title of this is The Association of Hypertension, Hypertension Duration, and Control with Incident Heart Failure. And this is in subgroups by race, and this was done in the REGARD study. So just a little bit about me. I'm a doctoral student in the Department of Epidemiology. I'm in my first year of the T32 pre-doc, about to be in the second year of it. My research interests broadly include cardiovascular disease treatment and outcomes, disparities research, as well as epidemiological methods. My advisor and mentor is Dr. Emily Levitan. Unfortunately, she was unable to attend today, but she's given her blessing on this. And then my committee members, so Dr. Levitan's the chair, and also Paul Muttner, George Howard, Dr. Reagan Durant, and Nancy Dunlap as well.
Quite a committee.
Yeah. So I thought I'd start just to give you a little background and rationale for this project. So I don't think it would surprise anybody if I said that heart failure is a leading contributor to cardiovascular disease burden. It's also a contributing public health concern. So there are about 915,000 incident cases in the U.S. annually. So these are new cases of heart failure. And the prevalence of heart failure is projected to increase through 2030, mainly because of the aging population and more manageable living with chronic conditions. So this is estimated to be about 8 million adults 18 years or older through 2030 that have heart failure, so about 46%. And additionally, there's a poor prognosis after a heart failure event. So for anybody who has a heart failure event, you have about a 1 in 2 chance of surviving 5 years after the event. And additionally, there is a high economic burden imposed on this. So heart failure costs about $30 billion annually in healthcare costs, time lost from work, as well as treatments. And additionally, we know that hypertension is a major modifiable risk factor for the development of heart failure. So some previous work has been done showing that there's as much as a 40% increased risk for heart failure for people with versus without hypertension. This was some earlier work that was done in the first National Health and Nutrition Examination Survey, or NHANES-1. And additionally, there is a pretty high population attributable risk for heart failure attributed to hypertension, so about 20%. And so essentially what the population attributable risk is that if you were able to completely remove hypertension from the entire population, you would be able to prevent about 20% of heart failure cases that we observe. And this attributable risk for hypertension is higher in females than males, so about double. So additionally, it's not necessarily do you have hypertension, it's how long have you had hypertension, when did it develop. So we know that the longer an individual has hypertension, this increases their risk of heart failure later in life. And additionally, individuals who are unable to control their hypertension are at a greater risk for heart failure as well. So the relationship between hypertension and incident heart failure may also vary by the pathophysiology of heart failure. So not all heart failure is created equal. So heart failure essentially imposes about the same risk in terms of morbidity and outcomes. However, the way that heart failure develops in an individual may vary by underlying disease. So heart failure is typically classified by the ejection fraction, and it's typically classified as either a preserved, reduced, or mid-range ejection fraction to kind of characterize heart failure. And the differences between these types of heart failure typically lie in structural abnormalities and remodeling. So for heart failure with a reduced ejection fraction, this is a situation where the heart doesn't contract normally, and so less blood is pumped to the body. So this is essentially an issue of volume overload. Whereas a heart failure with a preserved ejection fraction, the heart tends to contract normally, but the ventricles don't relax during filling. So this is more of a pressure overload related issue. And additionally, the relationship between hypertension and heart failure may vary by race. So there has been a lot of previous work looking at hypertension and heart failure and disparities related to this, and it's kind of been mixed. But what we do know from previous research is that hypertension tends to develop earlier in blacks compared to whites, and it's additionally a stronger risk factor for stroke outcomes as well as some renal outcomes in blacks compared to whites. So it's important to investigate these other cardiovascular disease events to see what disparities exist. And black individuals compared to white individuals typically have an increased awareness as well as treatment for hypertension. And despite this, they're less likely to be able to control their hypertension. So they're about 27% less likely. And so we know that these can all impact the severity of disease and risk for heart failure down the road. And finally, previous studies on incident heart failure have been in predominantly white populations. So the Framingham study, which is based out of Massachusetts, is largely white. There's other studies like the cardiovascular health study, physicians health study that have looked at this, and these are largely white populations. So there's limited inference on minority populations, which is why it's important to study these racial differences if they exist. So just broadly, the primary analysis for this first aim was to examine the association between hypertension and incident heart failure. And this is done overall, as well as looking at differences by heart failure subtypes and in subgroups by race, so looking at black-white differences. As a sensitivity analysis, we examined the association between systolic blood pressure as a continuous variable as well and incident heart failure. And secondarily, we wanted to kind of get a broader picture of, it's not enough to know just what's your risk with hypertension. What is the kind of burden over an individual's lifetime, and how does that influence your risk for heart failure? So secondarily, we examined the association between duration of hypertension as well as hypertension control with incident heart failure. So why did we choose the REGARD study? So I'm not sure how many are familiar with the REGARD study. It stands for Reasons for Geographic and Racial Differences in Stroke Study. This was a population-based longitudinal cohort which was originally designed with the intent to examine stroke disparities and racial and regional differences in stroke outcomes. So this is a large population-based cohort. There are about 30,000 individuals enrolled into this study. And it's well suited to examine race because black individuals were actually oversampled for this study, as well as individuals living in the southeastern United States, which is termed the stroke belt and stroke buckle regions. And we know that these individuals have different comorbidity burdens. There's a lot more comorbidity in the southeastern United States, so we can look at regional disparities that way. Additionally, this cohort has a long period of follow-up, and it's still ongoing. So these individuals were enrolled between 2003 to 2007, and they were contacted every 6 months for telephone interviews after that to kind of assess, if they were hospitalized and different things of that nature. And there was lots of baseline data collected that makes this a really rich population to study. And additionally, this was a slightly older population, so we were able to identify a large number of heart failure events that were adjudicated by trained clinicians. So individuals 45 years of age and older were enrolled into the study. This is just a brief graphic. I'm sorry if it's a little blurry, just to kind of show the distribution of the REGARD study and show you that it truly is a population-based cohort with, even though participants were oversampled in the southeastern United States, there's generally a good representation across the United States in this population as well for white and black individuals. So the first part of this work, and I already touched on this a little bit at the last presentation for this in the fall, was the construction of a heart failure-free cohort. So when individuals were enrolled into the REGARD study at baseline, among all the covariate information that was collected, we also collected medication inventories on these individuals, asked about previous comorbidities. So this is based a little bit on some work that was done by Emily Levitan and others, including Monica Safford, to kind of develop an algorithm for what we thought was the best way to identify a heart failure-free cohort. And this, so first we wanted to exclude individuals with no follow-up time and who are missing information important to our study, like hypertension. So if they were missing information on hypertension, atrial fibrillation, things like that, we excluded those individuals. But then we additionally excluded individuals who, with their baseline medications, were taking heart failure specific combinations. So we excluded people who were taking digoxin without atrial fibrillation. And then I've listed some other of the exclusions here as well. And this was done, there's some validation work that was done in the regards population that we were able to link to Medicare claims to kind of validate, their claims for heart failure, so that we could truly get the best idea of what like a heart failure-free cohort would look like. So all this to say, after these exclusions, we identified about 26,000 individuals who were considered heart failure-free in our cohort. And those are the individuals that we looked forward to identify their first heart failure events. So the outcome is incident heart failure. So medical records for heart failure hospitalizations were available through the end of 2014. And these were adjudicated by pairs of clinicians. So the primary outcome was any incident heart failure, so that first occurrence of an adjudicated heart failure hospitalization. So we identified about 855 of those. And for our secondary outcome, since we wanted to look at subtypes of heart failure, we had a list of criteria to identify those based on the adjudication process. So for heart failure with a preserved ejection fraction, anybody with a documented ejection fraction of 50 or greater, or a qualitative report of a normal ejection fraction were considered preserved. Heart failure with a reduced ejection fraction, those with an ejection fraction 40 or less, or a qualitative report of a low ejection fraction. We also had a mid-range of heart failure with mid-range ejection fraction. So this was anybody with ejection fraction between 41 and 49%. And you can see there's a small number here. I'll just go ahead and say for the main analyses, we essentially grouped these individuals with those with reduced ejection fraction to kind of have a split at the 50% mark for ejection fractions. So if this information wasn't available in the adjudication for that first heart failure event, we tried to classify as many heart failure events as possible. So for that, we additionally identified subsequent events for these individuals. If they had a second event within 18 months of that first heart failure event, we used that adjudication criteria to try to reclassify that first event. So basically, if we looked at the second event, if we were able to determine what subtype of heart failure that was, then we used that as a proxy for the first event as well. And then we additionally had some individuals who, for their first or a subsequent event, had none of that information listed on their adjudication form. So there were about 100 individuals. And for the overall analysis, these were included just to look at heart failure overall. When we looked at the specific types of heart failure, these were excluded from our analyses. So, as I mentioned at the beginning, we were looking at hypertension, the duration of hypertension, and then hypertension control. So I'll go through all of these quickly. So this was originally started back before the American Heart Association, American College of Cardiology had updated their guidelines for the management of blood pressure. We originally were using the old cutoff of 140/90 to determine hypertension. However, once this was updated in November, we decided to go with the kind of new definition of hypertension, 130/80. And this is mainly because, there's still an increased risk for cardiovascular disease outcomes in individuals who have blood pressure between 130 and 140, or systolic blood pressure between 130 and 140. As there was some pushback on this definition, Dr. Muntner is one of my committee members. He was actually on the writing committee for the hypertension guidelines, so he could probably explain it a little better than me. But essentially, the thought is that for these individuals, with blood pressure between 130 and 139, or diastolic between 81 and 89, lifestyle modification before treatment is kind of the route to go for them. So the goal of lowering it was not to prescribe more treatments for people. We wanted to also describe the duration of hypertension. So at the baseline interview, these individuals were asked questions about, have you been told you have high blood pressure? And they were asked if they responded affirmatively to kind of give it either a general age range or a specific age to kind of determine how long they've had their hypertension. So we classified these people. So the reference group for any of these would be no hypertension. For individuals who were never told hypertension, these were people who had measured blood pressure above 130/80, who were never told that they had hypertension, which may make a little sense if you think that the lower threshold for blood pressure wasn't around when these people were enrolled. But additionally, we classified people as having a duration of hypertension of less than 10 years or greater than or equal to 10 years. And then finally, for individuals who responded with information on antihypertensive medication treatment, we classified hypertension control as untreated hypertension, treated with a systolic or diastolic blood pressure less than 130/80, or treated with a systolic or diastolic blood pressure greater than or equal to 130/80. So we used survival analysis for this, so Cox proportional hazards regression to examine these associations. And I've listed the covariates here just in kind of the way that we modeled these. So the first model included age and sex adjustment. Our second model, we adjusted for the covariates in model 1, and we additionally modeled what are considered typically traditional cardiovascular disease risk factors like BMI, smoking, diabetes, cholesterol. And then for our final model, we included other potential confounders, so income, where individuals live, do they have health insurance, physical activity, stress, depressive symptoms. And in doing this, we've we tried to look at how age played a factor into this, because we know that older individuals tend to have a higher risk for heart failure overall. And we found an age interaction, like a linear age interaction. So we included these in our models. And so for the results that I'm reporting, we present age-specific hazard ratios for these individuals. And I'll kind of explain these a little more. So just to give a little idea about the baseline characteristics of these individuals. So using the lower threshold to define hypertension, we classified about 73% of these individuals in our heart failure-free population as having hypertension. With that said, even if we were using the threshold of 140/90 to define hypertension, that still caught about 60+% of these individuals. So there was an increase in the proportion that had hypertension, but it was not substantially greater than what we were using for the higher threshold as well. Participants with hypertension tended to have there were a higher proportion of Black participants among those with hypertension. There were really no differences by gender. Individuals with hypertension tended to have a higher proportion obese, and then more comorbidities as well. And I'm sorry that came off of this slide. I'm not sure why it's reformatted that for me. And they have roughly equal follow-up time in these groups. So we looked at these are age-specific hazard ratios for the association between hypertension and incident heart failure. This is not, so what we saw is that the hazard ratios we were getting actually tended to be larger for individuals at younger baseline age versus older baseline age. This isn't to say that the risk of hypertension is higher at younger versus older than baseline age. It's saying based on our participants who, when they were enrolled, were 55 years of age, tended to have a higher hazard ratio for incident heart failure. And what you can see is that the confidence intervals are a little larger at the tails, and that's probably because most of the cases for heart failure are actually concentrated around 65-year-olds, 75-year-olds, and those older age groups. But what we tended to see is almost a linear decrease in the hazard ratios that we were obtaining. But you can see comparing Black and white participants, they're not appreciably different. So the p-value was actually quite large for our race interaction, but because we wanted to see what these racial differences look like, we still presented these stratified results here. So if we look at the differences in heart failure subtypes, so you can see for white participants that almost linear kind of decrease in the relative risk for heart failure across age is held in the white participants. For Black participants, it's relatively similar across all ages. But the thing to note is that there's still an increased risk for incident heart failure associated with hypertension in both of these groups. And additionally, for heart failure with reduced ejection fraction, you can see here, again, these elevated hazard ratios. So we know that hypertension is a risk factor for incident heart failure. They're not necessarily different by race. And the reason that some of these maybe vary more for the Black participants is because we actually had a larger number of incident heart failure events identified in our white populations as well. So we know that having hypertension is bad, but how do these associations look when you're examining systolic blood pressure? So what we can see here is that across all ages and across the race groups, these relative risks for incident heart failure associated with systolic blood pressure tend to be relatively stable. So the risk is pretty evenly distributed across the range of systolic blood pressures. And I should clarify that these are relative risks per 10 millimeters of mercury increase in systolic blood pressure. So when we looked at the duration of hypertension, what we can see here is, again, for any duration of hypertension, whether it's a small duration, a long duration, there's an increased risk for incident heart failure, relatively similar among white and Black participants. And so these are individuals who had it for less than 10 years. If you look, these estimates are actually higher for individuals who had a greater duration of hypertension, which makes sense. So people who had hypertension longer tended to have a higher relative risk for a first heart failure event. But we still saw this kind of an interesting age interaction present in our modeling. And when I get to the next steps, I'll talk about how we're going to examine that a little more. And so we saw that people with a longer duration of hypertension had a higher risk for incident heart failure. So what does it look like when we have people with hypertension control? So we didn't actually see the kind of age interactions pop up in this association. So, but what we can see here are some pretty consistent trends. So people with uncontrolled hypertension tended to have the highest risk for having a first heart failure event compared to those who had controlled hypertension, and particularly, people with untreated hypertension still had a whatever level it was, tended to have an increased risk for first heart failure events. And so what this really gets at is that at any stage, whether your hypertension is developing younger in life, later in life, kind of the primordial prevention of that, as well as management of hypertension, is important in reducing your risk for heart failure events. Obviously, there are some limitations. So heart failure was only assessed in the inpatient setting. So anybody with an outpatient diagnosis or treatment was missing from the current analysis. And additionally, there may be unmeasured confounding present in our models. So some of the takeaways from this first aim is that the association between hypertension and incident heart failure was not statistically different by race. Hypertension was associated with an increased risk for heart failure overall, as well as the different subtypes of heart failure among all participants. And there was a linear decrease in the relative hazard for this hypertension and heart failure association, comparing participants with younger versus older baseline ages. Additionally, participants with a longer versus a shorter duration of hypertension had a stronger risk for incident heart failure. Again, this was not different by race. And uncontrolled hypertension was associated with a stronger hazard ratio for incident heart failure. And in Black versus white participants, this was stronger. So the next steps for this is to complete this manuscript for AIM-1. So we're conducting a sensitivity analysis where we're loading the population of participants 65 years of age or older. So we were seeing, those age interactions, and what may be there is that, there's a smaller number of cases concentrated for the people who were enrolled at younger baseline ages, because they just haven't had enough time to necessarily develop those heart failure events. So by doing this, we may get a better idea of what the risk associations look like just in this older population. After we do that, kind of the next thought for this is to more thoroughly examine these age interactions from AIM-1, as well as gender differences in the second part of this dissertation. So are the differences that we see by baseline ages due to an absolute difference in risk or more of a relative difference in risk? And again, that's kind of getting at the number of cases of heart failure that we're seeing And then is the association between hypertension and incident heart failure different for men and women? So with that, I'll stop there. I know I presented a lot of information. I'm happy to take any questions or comments you may have or thoughts for this analysis. Yeah.
Sorry, I'm losing my voice. I have two questions, and I'm going to apologize because it's going to show how little I remember from my survival class. So it seems like, particularly with your background and introduction, there was an emphasis on hypertension being one of your main variables of interest. And it seems like you ended up dichotomizing a lot of your variables related to hypertension, so you're losing a lot of the variation, a lot of the information you wanted to explore. And I suspect that has to do with sort of survival models and the baseline hazard and relativity, and I just don't remember the exact specifics, but then you had age as continuous. And so I think I'm just curious as to your choice to dichotomize there.
Yeah, so I mean, we dichotomized because we wanted to see, what is, particularly with this new kind of definition of hypertension, what that risk association looks like. But as a sensitivity analysis, we've done a more thorough kind of examination of what systolic blood pressure continuously, how systolic blood pressure continually is associated with hypertension. So there was that brief table that I showed you. We've actually done that with kind of all of our analyses to look at what it looks like as a linear blood pressure association.
And have you done that for duration? Because that was the one to me that would have been really interesting.
So, we haven't done that. Particularly the duration question is a little tricky because it's all based kind of on self-reported information as it is. So we're not really sure how reliable it is. That's definitely a possibility to look at. But as of now, we've just done the hypertension and duration association.
And my second question, again, which is how long ago I took survival. Are there quantile survival methods? Because it does seem to me that a lot of your exciting stuff, a lot of what you would want to know is at the tail. And to that extent, I was trying to think about it as you were presenting. It would seem to me that some sort of quantile method would actually give you a lot more interesting results. But I don't know what that looks like in survival, if I'm being honest.
I'm not sure how quantiles apply to survival analysis in particular. I know I have done some quantile regression. It's a little tricky to do, and you're also kind of having to make some assumptions with those quantiles in terms of kind of the ordering of risk. So like as you're increasing those quantiles, you're assuming that there's a particular, kind of set increase in risk between each group. And that may not necessarily be the case, but that's certainly something that we could look at.
Awesome. Thanks so much. You guys always support me when you present. It's our coverage.
Yeah. Building off something, and I might have missed this, in terms of assessing control, were there repeated measures at study visits to assess blood pressure control, or how is that ascertained, and how did you include that in the survival models?
Sure. So it's a slight limitation, but this all the extensive collection for this was done at baseline. So essentially at baseline, what we did was participants were asked, have you been told you have high blood pressure? Are you currently taking medication to lower your blood pressure? And so we have this, this question where people could respond negatively or affirmatively to that. And so essentially what we did was for people who said that they were not taking medications to control their blood pressure, we looked at people who had an elevated blood pressure and considered those untreated. For people who reported taking antihypertensive medication at baseline, we then additionally considered people treated or controlled versus uncontrolled hypertension. So controlled would be the reported taking medications at baseline, and their measured blood pressure was lower than 130/80.
Okay. So it's a cross-sectional baseline assessment.
Yeah.
Are there longitudinal study visits in regards to look at control over time? And
so actually, the second major in-home visit for regards, I believe, finished at the end of 2016. And they retained about, I think it was somewhere around 16,000 of the 30,000 original participants. So a lot of that data hasn't necessarily been cleaned yet. But if you were talking about a longitudinal assessment, there's really only those two major time points where those would have been assessed. So it would be interesting, if I'm hopefully not still working on this by the time all of it's clean, but if so, we could probably go back and look, between visit 1 and visit 2. Otherwise, they contact them every 6 months, but that's basically just to say, how are you feeling? Have you been hospitalized? And so that way they can go and kind of pull medical records and determine events.
Okay. And the second, I think, point that related to Monica's question about, if I understood, the fact that untreated hypertensive folks had lower hazards than treated, whether controlled or not controlled, might suggest some confounding by indication.
Sure.
Right? That the untreated folks have lower blood pressure, maybe fewer risk, other factors. So just thinking around along the lines of the sensitivity analyses, looking at, over a spectrum, because that group, you would think if they're as severe, that they should have a high, that some treatment, even if not controlled, is better than no treatment, and certainly controlled. So I think that just spoke to me of something, something's going on there, some confounding, maybe by indication or otherwise.
Yeah, that's a good point. So originally when this was done, it was limited to just people who have reported taking antihypertensive medications, and we basically just classified them as controlled or uncontrolled hypertension. So that untreated hypertension group was actually added in. So through some discussion between Emily and myself, basically just get at the idea of kind of a primordial prevention aspect. Mm-hmm. So, the earlier you can control, or the earlier you can prevent hypertension from developing and recognize it earlier and treat people earlier, then you're reducing the risk over a lifetime.
I have a question about your age interaction. So you found that hypertension was more predictive of heart failure when they're younger versus older, is that correct?
So what we saw was that the relative risk for people with a younger baseline age tended to be higher for incident heart failure than people who were at lower or older baseline ages. But we think that that's mainly indicative of the fact that there weren't many heart failure events that have occurred yet in people who are enrolled at those younger baseline ages. So you can see the confidence intervals are quite large. If you get down towards the kind of older ages, there's not as much variation in those confidence intervals. So we have a tighter confidence around that. But part of
and that's because heart failure was concentrated in those middle ages.
Yes.
Like,
yeah. And so by kind of looking at whether it's more of an absolute effect versus a relative effect, we can kind of get better at that, what's going on there.
What do you mean by absolute versus relative?
So is the risk there really because there are just fewer cases, as opposed to like an actual, what we're seeing in terms of absolute like heart failure incidents.
Well, could it just be too that like people age out, right? So like hypertension would be far more productive when you're younger because you don't have a lot of, eventually age will get you.
Yeah. So we've done a lot of analyses on these. I didn't add these in, but we actually, with our survival techniques, have done a couple of different methods. So there's what's called subdistribution hazard ratios. And this is essentially the idea of looking at competing risks. So we compared these risk associations for hypertension, controlling for competing risks of non-heart failure mortality, as well as administrative censoring. So to see, if you're taking out these competing risks, do those risk associations still hold? And they're actually still there. They just are slightly attenuated. And so because they're not appreciably different, we didn't present those with ours.
That was methodologically very intense. I got a really simple question, and maybe it just shows my misunderstanding. So when I saw those age effects and based upon baseline, I guess part of what I wondered back to your exclusion criteria was, were there more 65, 75, 85 years excluded from your non-heart failure cohort because they had already had events in the previous decade?
Well, so that's a possibility. However, our criteria were mainly just based on medication inventories. Yeah. So we basically were just kind of getting an idea of like what people were taking at baseline to determine whether they potentially had heart failures.
Yeah, I guess what I'm trying to get at is, were your 65-year-olds who were on one of those medicines because their incident heart failure event happened in the pre-regards 55 to 65 year age. So I'm just wondering if differentially by age,
You selected healthier people.
Yeah.
Selected people that hadn't yet had an incident event.
Right,
And that's
probably
part of
won't have one.
the age of
Yeah, that's a possibility. I think somewhere along the line I've actually had comparisons for those, and so we've been able to look at some of those differences. But obviously it makes sense that older people are going to be taking more medications. They'll probably have more comorbidities underlying at baseline, so they're more likely to already have had heart failure at some point.
Thank you, Matt.
Thanks.
So, good morning, everyone. My name is Sarah Rutland. This is going to be a little outside of my wheelhouse and a little different from, for example, my actual dissertation analysis. I've already kind of spoken about my dissertation to the TIPS committee, and I still don't have really good results to show you guys yet. I'm still incorporating suggestions and trying to get the data analysis off the ground. So instead, I thought I would present on a pet project I've kind of had for a while, and get the clinical, clinician and other health services research perspective on this idea. I've already written a paper because it was for a class. I took a class in patient care and ethics and relationships. And so when I was in that class, given that my topic that I usually look at is unmet need and the transition from adolescence to young adulthood, when we learned about the kind of the history and application of the 4 bioethical principles in medicine, I kind of started to think about where those principles fall into this age range that has changed throughout history to where now we kind of have prolonged adolescence. So the idea of childhood was new for a long time, and now we kind of have prolonged adolescence. And so I really specifically feedback on what sort of communications this might be appropriate for, like an op-ed versus a short communication piece versus a full paper, and what sort of journals might be good for it. And then also just if the idea kind of holds water to people who aren't sociologists, since that's all who have read the paper so far. So I'm sure we're all familiar with the 4 bioethical principles, the first being autonomy, and then beneficence, justice, and then non-maleficence. And I kind of wanted to make an easy to understand illustration, since this was just kind of a emerging, fleshed out idea, which is that as far as the principles are concerned, children essentially lack full autonomy. They don't have legal autonomy. They don't have full medical autonomy. And that's for, very specific and valid reasons that children, especially in younger ages, don't have the competency to make decisions for their care. And so their parents are responsible for their medical care in their medical home. And then you reach adulthood, and that is what the concept of autonomy is kind of designed for as adults. You kind of reach most medical autonomy at age 18 unless you have limitations that have been recorded and someone has authority over you. And then it's just the assumed competency that adults have. And so when I was kind of thinking about this principle and how it relates to people in an age range of 16 to 25, you kind of go from one day not having responsibility over your medical care and not having autonomy in a medical setting, absolutely. The next day you turn 18, well, now you have all these rights and responsibilities. So do the principles the concept of autonomy as it's described for the principles, is it really designed to transition young adults into wielding the responsibility that comes with bodily autonomy? So that's kind of the first idea, and how I think that, of course, many people have written about how the principles are guidelines, and in order for them to be effectively used, they're flexibly incorporated. But when I in the course of doing my research, there are some structural reasons why people who grow up in different like kind of SES settings might not be used to having like the independence and autonomy necessary to kind of make medical care decisions. And then you are then tasked with the full responsibility of your own care. I mean, you might be on your parents' insurance plan and everything, but the expectation is that you're supposed to reach an age where you're doing all these things yourself. You know, you understand your health care, you go when you need to, you're able to make your own appointments and have dialogues with clinicians. But I don't think just like the principles as described are really designed to like think about autonomy in that way for people in this age category. And the second concept that kind of, because it folds under autonomy, so naturally, is beneficence. So, you know, you have to make, like clinicians have to make decisions on children's behalf. And these decisions, for better or worse, can affect health across the life course. The common example I kind of see when reading this literature is that, you know, like treating childhood cancer, there are lots of health risks that would increase later in life. But of course, you're not going to make that part of the cornerstone of your decision when you're trying to save the child's life. And then for adults, the expectation is that adults are included in this decision making. And then the issues for beneficence tend to arise closer to the end of life in older ages, in terms of, you know, at this stage in this person's life, is continuance of care a benefit to them? Is it worth the risk entailed, et cetera? But again, we don't really see a lot of that discussion in the transitionary period, where children who become legal adults might have had continuity of care for chronic conditions, and now, you know, the responsibility of that is turned over to them. So what could we be doing more in healthcare to prepare young adults for wielding their autonomy, for understanding their role in decision-making and their inclusion in decision-making for healthcare? What models might support that? And then justice is really where my kind of like sociological lens comes in. So when I wrote this paper, of course I had to have like a sociological emphasis for it because it was still a social elective. And this is kind of where it fits, I think, most into my dissertation front end that I've kind of written so far. Justice is kind of inherently impossible for children in the principles because they don't have autonomy and they don't have power. And at the same time, like providing the same care to everyone is impossible due to structural inequalities and biases, and clinicians are not responsible for correcting, you know, the structural inequalities that have brought a person to their care. And even adults, though they have autonomy, they might have varied resources. And so serving justice to some people in different populations might be very difficult. And as I said, like providers can't fix structural inequalities. And that just is like inherently remains a barrier to equitable care for some people. And so in serving justice to young adults, a lot of the issues I think that arise are differences in how people are raised. So in the Works in Progress last week, we kind of talked about parenting styles. And one of the components in my dissertation is that some of the reason why unmet need might vary by SES, for example, might not just be, you know, the structural resources that are inherent in that, but the way that people of different SES origins are raised to interact with adults and feel that they have control over their lives. And so I use Annette LaRoe's research on concerted cultivation versus natural growth, which is probably familiar to some other like theories on parenting, but children who are concertedly cultivated is kind of the typical, what we would call now helicopter parenting, middle class, you know, raised to engage with adults, raised to speak up for themselves, raised to be responsible for various facets of their lives. Whereas natural growth parents tend to be like what we call free range parenting now, I guess. And it's usually taken by lower class parents because they don't have the time to supervise their children to the extent that helicopter parents do. So their children are given the free time to kind of do kind of whatever they want, but at the same time, they're expected to defer to adult authority in all situations. And so what she found is that in the medical setting, middle-class children at like elementary ages were already engaging with doctors, asking questions, versus the lower-class children who were told to sit there and be quiet and not, like talk back to the doctor kind of thing. And so throughout the life course, that makes applying justice to all people difficult. But in the young adult transition, where all of this responsibility is basically converted, how do you serve that population more equitably to where they become adults who are what we assume is happening in the principles, where they get autonomy over their body, they go to the doctor and get the most fair treatment possible, and then go about their day. And so I didn't want to write a manuscript without any proposed solutions. But there is one person who had an article come out in Bioethics recently talking about transitional paternalism, where when an adolescent, assuming they are in the healthcare system, is reaching the ages of 16, 17, they're kind of mentored into, this is how your healthcare works, and, this is the sort of decisions you'll be making in the future for yourself when you get older, to kind of prepare them for that task. And non-maleficence, of course, is always a constant. I'm not arguing that no one cares about the health of young adults at all. So in tying it together, I've been doing some writing on how unmet need for healthcare in this population, how it might tie into it, as I discussed with parenting styles and some of that more sociological lens. And then I kind of had this question when I was making this dissertation: are the difficulties applying the principles a reflection of structural issues affecting adults and healthcare in general? So we don't really have a system in place where young adults have high rates of insurance, high access to insurance, the resources to go to the doctor when they think they might need it. And so as a result, it just is kind of natural that the principles might not have been made to be applied for people who are kind of already falling through the cracks. And that's kind of what, in the data I've seen so far in young adult health and unmet need for healthcare, is kind of what that is in general. It's the young adults who fall through the cracks of the system because they used to have a medical home and their parents responsible for their healthcare. And then in the transition, when there are vast disparities in income, insurance, education, there are just pockets of young adults who just kind of fall off that continuity of care. And so I've been trying to decide whether this is just a good topic to kind of have a short discussion on how the bioethical principles might apply differently to this population, or if it should be more of how does unmet need tie into the bioethical principles in this population. So kind of back to the, for this idea, what sort of piece is it suited for? Does the discussion hold water for a clinical audience or people outside of just ethical discussions? And what else I should consider? This is very much a work in progress. I have a paper written, an academic long paper, and I would like to kind of take some of the ideas and make them, something different than what I typically do, which is numbers. So that's basically what I have, and I can go back to any of the other slides and we can talk about them. But yeah, I just general feedback.
So I'd like
to offer a little bit different perspective on just this. If you could maybe go back to that slide. So basically, the assumption here is that it's impossible to provide the same care to all children because of structural inequalities versus in adults. That may not be the case, at least not to that extent. I'll actually disagree with this when it comes to chronic diseases. I'm not sure whether that will apply to pediatric population that's healthy.
Mm-hmm.
But children who do have some sort of a condition that has been diagnosed and followed actually receive same care regardless of income or education or any socioeconomic factors because they have universal access to insurance.
Mm-hmm.
The falling off the cliff really happens when they're 18 because suddenly there is no safety net to hold them. I mean, every state has some sort of a CHIP program, Medicaid, and all children are covered. Now, there are health disparities in outcomes, but they are not due to access to care. They're due to those like social structural influences that happen outside of clinical setting and communication. They are not attributable largely to what happens in clinical care. So I think it's flipped when it comes to children with chronic conditions.
Okay. That's a good point.
The other thing is transition for children with chronic diseases. Actually, transitioning from age 14 to adult clinic is fairly structured and well organized. Not in the primary care setting if they're not like followed continuously for a chronic disease, but if they are followed, I mean, there's special transition clinic in the majority of chronic conditions. What happens is that the child age 14 through whenever they go to adult care is first seen by themselves. And then together with a parent during the same clinic visit. So they're sort of transitioning them into assuming responsibilities for their care, managing their condition, dealing with pharmacy insurance and whatnot. So maybe we would like to kind of investigate a bit more what goes on there for those children with chronic diseases, or take them out of this argument because somebody may have the thoughts that I did.
Okay. Kind of related to that, when I was kind of thinking about the rise of student health centers and universities and how for, basically the sort of kids who make it to college, how that kind of helps them transition into continuity of care, which isn't a resource that all people in that age range have, where you have a place that you kind of is built for you to go to, and maybe that helps some people who don't necessarily have chronic conditions develop mastery of the healthcare system and their own healthcare management in those years that not all people have access to. I kind of thought about that.
And if they're in the university, they're more likely to have an insurance plan that's going to cover until they're 26. So access again is not as much of an issue for the population. One interesting specialty that might be kind of fascinating to contrast with a lot of the specialty clinics is the congenital heart center here, because they continue to see patients from the time that they're babies to the time through adulthood. You don't transition to a regular cardiologist. You stick with the pediatric cardiologist because it's a very specific kind of disease. So it might be kind of fascinating to check out a couple of the specialty clinics and then speak with a couple of the cardiologists there, because they get to observe this process without a break in care or a shift. So it'd be interesting to get their feedback too from a clinical standpoint. I have a comment. I don't know how helpful it's going to be to you, but in general surgery, we do pediatric surgery and then adulthood surgery, so we serve both populations. And so we're taught to, for informed consent, which you can argue that, but you talk to the patient that you're performing the operation on. So we do that in the pediatric population and even in the adult population if they aren't competent to sign their own forms. And so you're having that conversation with that patient, with the person available, and you answer questions for both. But I have kids that if they're willing, I have them sign their own consent forms and have their parents sign the guardian consent forms to have them as involved as possible.
And I also do that with the adult population if people are willing to sign. Because what you really need is that the guardian's signature, the under 18, or that's the person making the decision for them for legal purposes. But you should try and have that person as involved as possible, even if they're not the person who can technically make their own decisions. And I feel like that sometimes gets patients to ask more questions if you're directing it towards them. And I just feel like some of the pieces were harder, like beneficence. I feel like we talk about risks and benefits of surgery across all types, not necessarily end of life or anything like that. So I don't know, just a comment on how helpful that is, or if there's any literature out there for surgery.
Yeah, that would be a good population because, I mean, the people who like gain access to surgery a lot of times, I guess, would be different than people who like don't have health problems that advance them to like surgery. And I'm not like, basically I'm not arguing that like clinicians like don't do this or don't do that. It's like, do the principles themselves not really have like what's built into them to apply to people throughout every stage of life course?
And I guess my comment in reading your paper then would be like, well, what would you suggest they be? Like, if you say you want to give solutions, I would say give me the things that you think should be there to fill those holes.
Okay, yeah.
So it's interesting to hear different perspectives. So I think you did a great job like stimulating thought, because my mind went to wellness and prevention and health promotion, not chronic disease management. So I went to thinking about, again, you think about the world, so I'm an HIV provider, and think about HIV prevention, and then more broadly sexual and reproductive health. So, you know, in an area where adolescence and HIV has been defined as up to 24, this idea of prolonged adolescence or extended adolescence, something that's there, and thinking about applying, I think it's really thoughtful, but applying this into the frame of sexual and reproductive health among both women and men, especially among men, among gay and bisexual men, where we see, you know, you go through, get immunizations, things like HPV, you're not involved with those things, and then at some point you turn 18 and all of a sudden now, whether it's contraception, you know, and family planning, we see real issues or challenges with young men who have sex with men around kind of biomedical prevention modalities and accessing those things. So my mind went to thinking about, I guess maybe less about do these principles fall short, or in terms of around sexual and reproductive health, how do you cultivate, you know, control, decision-making, shared decision-making, you know, in this context of structural inequalities, was kind of where I went. So, you know, I guess part of it, thinking about it broadly, different thinking for chronic disease management versus specific conditions versus surgery versus wellness health promotion. I do think, again, this is the lens that I know best, but thinking about it from a wellness health promotion, sexual reproductive health, there you could go into a rich discussion as it relates to both kind of, you know, pregnancy, family planning, sexual transmitted infections, and HIV prevention.
Okay.
And I have another thought, actually. Thank you. This is really good to see how it does not apply equally across the spectrum, but may, you know, be differently valid depending on, yeah. But something else I was thinking, it seems to me like going back to the autonomy, maybe the pendulum has swung way too far in the opposite direction of giving too much autonomy that with the intention of benefiting children, but that actually may end up hurting children. And a specific example is how HIPAA is being used, for example, by insurance companies, so as to, until the age of 26, your children may be on your insurance plan, right? So you're paying for them. But actually, when they turn 14, you do not have access to the medical records without their signed consent and permission. So you are liable for the bill, you pay the bill, you do not know what the bill is for, unless you receive a written permission by your 14-year-old. Like, understand what the intent is, right? Is it applied rightly? I don't know, does it benefit the child? Maybe, maybe not. I think that's really interesting to look into as well. Especially for children with chronic diseases. Oh, receive care all the time, and they're supposed to make those decisions at the age of 14 themselves. Obviously, the parent will take them there. They can't drive, right?
Yeah.
And the parent will pay for it, but the parent can't see the medical record. What if there's an error in the what if something's built incorrectly? Parent can follow up without permission of their child. Anyway, just interesting to
Well, and the autonomy was the thing that like I found most, it, like got my wheels turning the most. Like I wanted to try and like piece apart, you know, how all four of them might, you know, like not equally apply. But I feel like I could really just focus on autonomy for some populations, the adultification of children, and like probably just write like a piece that's just about like how autonomy, you know, shifts through this transition for mastery of healthcare and access to healthcare and all of that.
One interesting thing to look at might be high schools all do sort of a life course where they teach you how to balance a checkbook, and I'd be interested to see how many actually.
They don't do it anymore.
Really?
Yeah.
I didn't have that.
For the most part, they don't do it at all anymore.
Really? My kid's school does. I was just thinking it'd be interesting to see if any of them ever talk anything about just the basics of how to access healthcare, because that's a part of life.
One more comment in the back, and then we'll save time for Katie.
Okay, I think really that everybody that has spoken, we're all correct. It could be used broadly, it could be used for chronic illnesses. And so I'm a child psychiatry fellow. I'm graduating next month, and I have taken a faculty position. I will actually be starting a clinic, transitional age youth. And so American Academy of Child and Adolescent Psychiatry is really a new area, and you're very, very correct that this population is really neglected. But recently it has become a population of interest, even for the academy, because really the needs of the children are completely different from the needs of those population, like the tier 1, and that of adults. And so you can use it from my clinic, seeing adults that have simply depression or anxiety. Transition from high school to college is a very stressful period. You're not driving. For the most part, you've been dependent on your parents or a guardian to provide everything. Even if you're healthy, super healthy, most of them crash at this point in their life. And so we could use it preventionally as a prevention or wellness or health promotion. But we will find out that those of our kids that have ADHD or depression get worse even at this point of transition. And so what I'm really looking into, this population is neglected, and neurodevelopmentally, the brain, they're kids, they're not adults, but then the social demands that is placed on them is that of adults, and they're not like mature to take them on. And so I think autonomy can be applied to that, and also justice. The issue of SES comes in handy. It's great. I've presented a ground rounds on it, and I'm looking for ideas. I mean, I have to provide a clinic protocol. And I saw this topic and I came, and I think both of us can talk and see what we could do. It's really a huge area and a huge area of need, so I think it can be used broadly.
We should talk.
Yeah, Sarah, thanks for sharing. So, trying to summarize, a lot of interest. So you're on something.
Yeah, I mean, I wrote the paper, so I feel like, you know, like there's probably something in there
It sounds like
that
your
I could
audience would
cultivate.
share that, would validate that. Thank you for sharing.
I think I designed this to be a little short, hopefully I did. I call this disentangling, so I'm not sure if I'm going to make more sense of this topic or less sense of this topic, but I'm going to try to make more sense of it. This is primarily what I've been working on over the past year, really our lab has been working on over the past year. So I wanted to sort of follow up my talk from, I think, October with some data and sort of what I'm doing with this intersectional stigma piece of work. So I will reorient everyone to stigma and its dimensions and intersectionality. I will talk about this work in progress. I'm presenting this, it wasn't abstract, but I'm presenting a data blitz on this topic, the cross-level and cross-sectional associations between anticipated HIV stigma in the community and sexual orientation, discrimination, and HIV treatment self-efficacy. In a data blitz, I have to condense this down to 2 slides and 2 minutes of content. So I figured at least talking it out now would help me to maybe hone in on the points I'm going to do that with. And then I'll talk about some take-home messages. So to bring everybody back to social psychology, so I know not everyone in this room spends every day thinking about stigma. Stigma exists in our society. It manifests itself through these cognitive manifestations of stereotypes. We have these affective prejudices, beliefs about stigmatized identities or traits, and those get manifested as behaviorally as discrimination towards people who we perceive or do have those stigmatized traits. Stigma intersectionality acknowledges the fact that people don't necessarily live with just one identity or trait. So someone who is living with HIV may be stigmatized because of their HIV status, but they may also encounter racial discrimination, sexual orientation discrimination, discrimination due to substance use or mental health concerns, chronic pain stigma, the list goes on, poverty stigma, and these can all interact in ways to affect health outcomes. Studying intersectionality is tricky, and as a field, I think we're trying to wrap our heads around how to do that, and there's a lot of interest in that field, where a lot of people are trying to figure out the best methods to go about measuring and looking at how these different forms of stigma and discrimination affect health outcomes. And taking this approach also acknowledges that people may have sources of resilience. It might not be additive, that discrimination affects everyone, terribly and leads to really bad outcomes. There might be spaces where people can sort of grow from experiences of discrimination and stigma. Obviously, we want to eliminate it altogether, but that is a kind of idealist goal. At the individual level of someone who is stigmatized, stigma can affect them in ways that they might anticipate stigma. So this sort of comes out as like worry or anticipation that, when I leave my house or even in my house, my family's going to treat me differently, or just people in my community are going to treat me badly. I'm just anticipating something's going to happen. I'm always kind of vigilant of that. Internalized stigma is when we kind of take stigmatized beliefs, stereotypes, prejudices, and we kind of turn them in towards ourselves. So beliefs, so in HIV, stigma that might be believing that I'm a bad person because I got HIV. Enacted stigma are experiences of discrimination or just being treated differently in your world. And then Dr. Tron sort of added on the perceived stigma in the community to this kind of framework of stigma mechanisms that can act on a person and affect their health and well-being. This is clinically relevant as these stigma mechanisms can interact with one another to affect different health outcomes. I'm going to focus on how anticipated stigma from one's community interacts with experiences of discrimination to affect treatment self-efficacy in people living with HIV. So my question is, does anticipated community HIV stigma interact with sexual orientation, different experiences of discrimination to affect treatment self-efficacy among men living with HIV? We had a sample of about 109 men recruited out of the 1917 clinic, and we're able to look at this using daily analyses as well as cross-sectional analyses to add kind of a different layers of looking at these interactions. So in our daily analyses, we used experience sampling method, also known as ecological momentary assessment, 3 times a day for 7 days, and then did sort of time-lagged analyses to look at how experiences of sexual orientation discrimination affected treatment self-efficacy on a daily level. So how does your confidence and your ability to stick to your treatment plan, to take your medications, kind of change throughout the day and day to day? Based on your endorsement of having experienced discrimination. And then we also had them answer questionnaires of sort of more global measures of these constructs. So I will go on to show kind of how this looks graphically, but in our time-liked analyses, it was sexual orientation discrimination that was associated with later treatment self-efficacy, and anticipated HIV stigma had a significant main effect on later treatment self-efficacy, both at the intercept, and it affected how that changed over time. So this is what this kind of looks like. At high levels of anticipated community, or anticipate, so if I perceive that I'm going to be treated, or I think I'm vigilant that I'm going to be treated badly because of my HIV status in my community, experiences of sexual orientation discrimination actually lower my treatment self-efficacy on a daily level. And in the alternative model where we looked at racial discrimination as a predictor instead of sexual orientation discrimination, there was a main effect of anticipated HIV stigma in the community, but there was not an interaction between the two. When we look at the cross-sectional effects, we find something different and interestingly. So when we look at sort of the ways that these are answered in questionnaires, it's actually at low levels of anticipated community HIV stigma that experiences of sexual orientation discrimination predict lower adherence self-efficacy. Whereas at high levels of HIV stigma in the community, there was not an effect. So that is quite different from what we found at the daily level. And when the alternative model was run, the results were actually similar, where racial discrimination, when that was low, anticipated community HIV stigma was associated with lower adherence self-efficacy. It's confusing. I acknowledge that. So I'm a little puzzled about the different effects daily versus cross-sectionally. I think this just sort of points to how you measure matters. So these effects are certainly not additive. And we see sort of these protective, well, it would almost seem as it's sort of protective at the daily level, where if you're experiencing sexual orientation discrimination, it seems to sort of protect you from kind of the anticipated community stigma, which isn't to say that, oh, everyone should experience discrimination, that's going to be good for you down the line, but I think that we can acknowledge that experiences of discrimination can kind of build resilience and hardiness, and we kind of have to acknowledge that. And again, how you measure matters. And sort of going back to the non-additive, when I kind of broke this down and looked at these different forms of discrimination, you kind of see that the community anticipated seems to be highest amongst our white heterosexual men and a little lower between more of kind of our minority individuals, which is just sort of interesting, and again, sort of thinking how to make sense of this. So I appreciate any thoughts about this as I'm trying to wrap my head around all these findings and make more sense of them.
Okay, so you said you have to do this in like 2 slides down the line?
Yes.
Yep. Okay, so I'm going to see if I can like do this in a 1-sentence takeaway and have you tell me where I'm getting this wrong.
Sure.
So to me, there seems like there's some self-fulfilling prophecy aspect of if I'm right, sort of perceiving or expecting stigma downstream, right, effects. Am I getting that right? There's a self-fulfilling prophecy aspect, but there's also a protective aspect. There's some like competing mechanisms going on. Is that it? Or no? Because everyone's looking at me like I'm crazy.
I don't know if it's a self-fulfilling prophecy. I think it's sort of getting at like how your environment and how your daily, or how your experiences interact. So the anticipated stigma is in the community is really kind of like, what does your environment look like? Are you anticipating like when you are out in the world that you're going to be treated differently or badly because of your HIV. And then the discrimination pieces are like, what experiences have you actually had of being treated this way?
But the perceived one had the more intuitive sort of results, right? That like if I perceive I'm going to be stigmatized, right, what was it? Self-efficacy, was that the actual?
Yeah, treatment self-efficacy, yeah.
Yeah, like if I sort of expected high, if I perceived high stigma, I would have lower. Was that correct? Is that this sort of like and done?
Yeah.
Because that's, I guess, where I'm thinking, because it's self-perceived, that's a bit of a I mean, it's not entirely a self-fulfilling prophecy, but that's where I'm sort of getting that idea, maybe.
Mm-hmm.
But then in the following one, there also seems to be some sort of coping mechanism, right? Where if I experience some type of environment sort of long enough, perhaps, or I'm in that I learn to sort of cope and respond appropriately. And I guess those are the two takeaways I'm getting. And I don't know.
What I suspect is, you know, you probably had quite a lot of experiences, or a person maybe has had a lot of experiences of sexual orientation discrimination through their life, because it's something, you know, maybe they're out about it or maybe they're not, and that would certainly determine kind of their level of experiences. But they probably do catch on to kind of how to cope with those situations. So when an experience of HIV discrimination comes down the pipe, they sort of already know what to do. Or maybe they'll anticipate less. Or more, I'm not sure. Or maybe if I'm anticipating more and then this happens, then that doesn't really affect me, or it does. Yes.
I was just gonna say, like, discrimination in health research has been like a big field for a while now, and when we interview white men and ask them about their discrimination experiences, those who have had it really impact their health, like far more than it does, like, you know, people of color. So I wonder if you're like picking up on some of that, like, and even with stigma, right? Like, people who fear stigma and don't do things because of fear of stigma tend to be like higher SES people. We have more to lose, basically. So I wonder if you're picking up on some of those aspects when you have like the unexpected effect of, what is it, community stigma, interacting with discrimination or sexual discrimination.
Yeah. Yeah, and well, with discrimination, when it does, it's sort of a rare occurrence, but when it does happen, it's quite impactful, which I think is sort of what's there. And I think in perhaps these cross-sectional effects, what we might be seeing, in low anticipate. So I'm not anticipating something's going to happen to me, and then something happens to me, and then that's bad, and that really throws me off my kilter and affects my kind of confidence in my ability to adhere to treatment. But at the daily level, that seems not to be true. When I'm expecting maybe I'm going to be discriminated against from an HIV stigma, and then something happens that does reduce my daily ability to adhere, or confidence in my ability to adhere. Yeah.
Can you explain a little bit about why you chose anticipated community HIV stigma, but then you're contrasting it with the experiences of sexual orientation discrimination, as opposed to having it be the same thing? I'm anticipating this, and then I'm not getting something about the difference.
It's the intersectional piece. So I did look at this with HIV discrimination as well, and that didn't have any effect on treatment self-efficacy here. It didn't even have a main effect. But sexual orientation discrimination did. And so I was looking at how these different things intersect. So if I'm anticipating there's a lot of HIV stigma in my community, it's sort of like looking at, like, how does this look different for sexual majority versus sexual minority folks and racial minority and racial majority folks? Does the level of HIV stigma sort of they're anticipating in their community interact with maybe the discriminatory experiences they're having based on these other traits to affect the treatment outcome? Treatment self-efficacy outcome.
I'm trying to wrap my head around. I'm trying to wrap my head around. So I mean, if I'm following this slide and the next slide, it's this idea that my daily experiences and what I'm reporting when you're measuring me 3 times a day for 7 days are different than my perception when I sit down after a time period and I'm asked to report about my thoughts on these globally.
Yeah.
So I mean, it speaks to something about the way people are processing and thinking about, and it speaks, so that's just trying to wrap my head around why, if this is the experience you reported on, on your phone, when you sit down and kind of try to reflect, and is there something different about the process of capturing data in this method where, people are, and what kind of biases or what might be going into someone's responding to this cross-sectional global versus this day-to-day kind of, what do you feel? I mean, what are you experiencing?
Right, it's different. It's momentary versus kind of these cognitive approximations of overall experience. So one could say that these are kind of more accurate, because like in the moment, how confident are you feeling? I would argue that might be a little more accurate than asking someone to say, okay, over this past 6 months, how confident did you feel in your ability to adhere to your medication? That changes daily based on maybe your mood, based on these social experiences, based on just fluke changes in your schedule.
I mean, you just kind of begs to me to wonder, I mean, could you sit down and do in-depth interviews with folks, you know what I mean? Like, and try to understand, I don't know, I mean, just trying to wrap my head around understanding this makes sense as an intuitive, and the next one, everything, so just,
Well, I think they each can make sense in isolation. It's when you put them together that it makes your head spin a little bit. I will promote Dr. Rice's recent publication in Social Science and Medicine, where she has a lot of qualitative work with women explaining intersectional aspects of stigma, and it's a really great paper.
But the low, medium, high folks are categorized the same way in these two. So it's the same, and do you know in terms of how the low, medium, high folks do in terms of beyond their self-efficacy, their actual adherence behavior or viral loads?
I would assume self-efficacy is a mediator of that, so it doesn't bear out to like main effects on those two. I'd have to revisit those analyses, but I think the self-efficacy sort of that would be a very complicated model.
No, I'm trying to think more simply, just looking at low, medium, high, and the actual behavior of adherence and viral suppression, and just trying to disentangle,
So you're including heterosexual individuals as well, and so I'm wondering if part of what you're seeing is maybe the fact that, for a lot of those individuals, they're obviously they're going to have low sexual orientation discrimination scores, so, they may kind of be concentrated towards the kind of the front end of your graph. So you may, I mean, I know your sample size is small, but you can probably parse that out and see, if you separate the heterosexual individuals, specifically white heterosexual individuals, who probably have completely different discrimination perceptions compared to, say, a black male, gay with HIV.
Right.
And I think, maybe looking at some of those differences may be able to disentangle it a little bit, what you're seeing.
Yeah, it's interesting, and I don't think, I'm not thinking, these are kind of flukes, because we find very similar things with depression as well, how these different stigma mechanisms interact. So there's something to this, but it's making the story out of it that is a little puzzling.
Yeah, I think it makes sense, like in the bottom chart, if you look at your white heterosexual individuals, obviously they have the highest kind of anticipation of community stigma, and just anticipated stigma in general that goes along with HIV, because they don't identify as gay or bisexual, but having HIV obviously sets them up to have more of a perception that they're going to be perceived maybe in some kind of negative aspect.
Can I just make a kind of a comment?
Sure.
So I like this slide. It shows the interactions of the status and the variables that you're looking at. I would personally avoid like looking at the interaction graphs if you have 2 slides.
Yeah.
And just say I did interactions and this is what happened. But
That's a really good point.
I know that when we worked on interaction, it is so complicated for even the person doing it to explain, much less for the person who is standing there for a 2-minute presentation to try to understand it. Because I would be standing there staring at the graph while you were talking and trying to understand what that meant. But that, to me, kind of summarizes everything that you're trying to say or get at in that 2 minutes.
Yeah, that's helpful.